Thank you so much. Thyroid receptors, where are they located? Thyroid hormone regulation. So instead of going all the way back, I want you guys to answer a few questions. Let me know how much do you guys remember from our last week. Where do we have the receptors for thyroid hormone receptors? That means receptors for T3 and T4. Can anybody answer my question? Yes, intranuclear. Good, right? So intranuclear receptors within, yes, it's inside the nucleus. This is the cell nucleus, and this is where thyroid hormone T3 receptors are. Okay. And what is how is thyroid hormone secretion regulated? One of you can even annotate for me on the screen, on the whiteboard. Okay. Negative feedback starts with hypothalamus. What does hypothalamus? Okay, yes, likely. Yeah, go on. Good. Okay. TSH. Yes. TRH from hypothalamus regulates TSH secretion from anterior pituitary, and then anterior pituitary controls the secretion of T3 and T4. Okay. What are the functions? What are the functions of thyroid hormone? What do they do? Metabolism, right? So under the influence of thyroid hormone, cell produces a variety of enzymes which are responsible for regulation of most of the metabolic pathways. So metabolism, right? Good, right? All right, so let's start with our class, okay? So this is a summary of physiological effects of thyroid hormones, all right? So there is increased transcription of large number of genes, right? So because any hormone that enters the cell, okay, all the steroid hormones and thyroid hormones, the principal way of the principal mechanism of their action is by transcription of variety of genes, okay, so that these genes then direct the formation, synthesis of new proteins responsible for all the actions, okay. Increased cellular metabolic activity, increased number and activity of mitochondria, active transport of ions, increased heat production, okay. Of course, because metabolism, normal metabolic rate is required for growth, so growth is very important function. Carbohydrate metabolism, what kind of hormone is it glucogenic or non-glucogenic? Glucogenic, right? It increases the formation of glucose principally by glycogenolysis and then also gluconeogenesis in the whenever there's a need. So it is kind of, you can say that it is a co-stressor. It's not the stressor hormone, but its levels, they increase when we are some kind of stress, right? Fat metabolism, increased lipolysis, free fatty acid levels in the plasma are increased, and enhanced beta oxidation of free fatty acids. Plasma and liver fats, increased thyroid hormone decreases concentration of cholesterol. So cholesterol levels, they are kept in check by normal levels of thyroid hormones. There's another very important function. It is not mentioned like at many places. You can write it down. It's not that I'm going to test you on this, but very important function, which I thought was missing in our PowerPoint, that is increases the number of, I think it's there in one of the places, but not at many places. It's a very important effect. Increases the number of adrenergic receptors. the target tissues, right? You have to remember this. So all the cardiovascular effects of thyroid hormone are because of this. This is called priming effect. That is this function of one hormone when it sensitizes target tissue for another hormone is called priming. Okay, so that means thyroid hormone primes the target tissue for effect of norepinephrine, right? So this is priming function of thyroid hormone. All right. Okay, so let's move on. So we talked about this, right? Metabolic rate is very low in hypothyroid individuals, and it increases like too much in case of like if you have increased level of thyroid hormone in the body. So these are the effects of increased level of thyroid hormone, decreased body weight, increased blood flow and cardiac output, increased heart rate, increased strength of the heart. This is due to priming effect. Okay, priming effect. All right. Keeps the mean arterial pressure normal, increases rate of respiration, and gastrointestinal effect is there is increased rate of secretion. That is primary effect of thyroid hormone. That is not the priming effect. Why am I saying that? Because what is the effect of sympathetic versus parasympathetic on gastrointestinal tract? I think you've read autonomic nervous system in one of your courses, right? What is? Okay, so what happens when you are in sympathetic state? What happens to your GI motility? Decreases, right? So, right, decreased GI motility, secretion. In general, sympathetic nervous system depresses your gastrointestinal tract. Parasympathetic nervous system increases all the GI functions. All right. So that's why I'm saying this is the direct effect of thyroid hormone. It increases GI activity. Okay. And whenever you have deficiency, there is, yeah, thyroid hormone, it does not slow down, it increases motility and secretions. Okay. Good. So these are direct and indirect cardiac effects, and we talked about it. And overall, there is increased cardiac rate and output. Okay. Increased blood volume, and that causes cardiac output and increased heart rate, right? In the muscles, there is, central nervous system, there is increased cerebration, again, due to metabolic effect, extreme nervousness, and likely psychoneurotic tendencies in case of increased levels, fine muscle tremors, increased vigor. In greater excesses, it leads to weaknesses. Okay. Insomnia. The hyperthyroid patient will be insomnic. Okay, will not be able to sleep even, when this person is tired. Okay. Increased rate of secretion, that is the effect on other endocrine glands. That is again because of metabolic role. Okay, and we talked about it. In males, great excesses cause impotence, and lack causes loss of libido. And in females, I told you this is paradoxical. A hypothyroid female will lose more blood. Hyperthyroid female will go into amenorrhea or oligomenorrhea. Okay. Then this is the contrast between hypo and hyperthyroid individuals. Decreased gluconeogenesis, decreased glycogenolysis, right? Protein metabolism, there is decreased synthesis and also decreased proteolysis. So overall, there's a balance, but increased serum cholesterol levels whenever a person's, thyroid levels are low, person is cold intolerant, and normal level of serum catecholamines in autonomic nervous system. A hyperthyroid individual will have increased gluconeogenesis and glycogenolysis, increased synthesis. Because you know why serum glucose level is kept normal? In spite of glucogenic effect, if a person is hyperthyroid, this person is utilizing glucose at a higher rate because this person's metabolic rate is very high, right? muscle wasting, okay, reduced serum cholesterol, increased lipolysis and increased lipogenesis. Both thermogenesis is increased, so heat intolerant, and increased expression of beta receptors on the target or target tissues, right? Then we started talking about thyrotoxicosis. So there is primary hyperthyroidism when thyroid gland becomes, starts functioning more, starts secreting more T3, T4. So this disorder means this is primary. This is the disorder of the thyroid gland. Graves' disease, where there is formation of thyroid stimulating immunoglobulin. Toxic multinodular goiter, there can be formation of multiple nodules and they just start producing too much thyroid hormone. Toxic adenoma means a single nodule. Sometimes they used to call it solitary nodule. And when we were studying, like some of the books, they will call toxic adenoma as solitary nodule toxic. So solitary nodule can be toxic, can be hypothyroid, hypofunctioning, can be non-functional, can be cancerous, anything, okay? Thyroid carcinoma, some types of thyroid carcinoma, they make thyroid gland produce too much of thyroid hormones. Then there is thyrotoxicosis without hyperthyroidism, that is thyroiditis, or iatrogenic, when you're giving like thyroid, a patient is on thyroid supplement, but is like accidentally taking like too much of it, like in double dose or something like that. Secondary hyperthyroidism, maybe something is wrong with the pituitary gland, it is secreting too much TSH, or there is primary disease of hypothalamus and is making thyroid gland work more, all right? But there are signs and symptoms of thyrotoxicosis, and if you will look at this patient, will be hyperactive, irritable, dysphoric, heat intolerant. Patient will be sweating in spite of like, cold room temperature. Patient will complain of palpitation, fatigability and weakness, weight loss, increased appetite. So weight loss in spite of increased appetite. Yeah, secondary is when the primary defect is not in the thyroid gland, that is secondary. Okay, that means the defect is from somewhere else than the source of disease. All right. Okay, does that answer your question? Diarrhea because of increased GI motility and oligomenorrhea. If you'll examine the patient, there's tachycardia, atrial fibrillation, again because of increased sympathetic, I would say priming, tremor, there may or may not be goiter, warm, moist skin, muscle weakness, proximal myopathy, lid retraction or lag. We are going to look at the picture of lid retraction and gynecomastia in males. This is unexplained why there is gynecomastia in males. And there is another thing, there will be there'll be signs of vitamin deficiencies. Why? Typically, when you will see a hyperthyroid patient and this patient is like having this disorder for like a few months, you will see the signs of this patient is going to have angular stomatitis, pale skin, maybe deficiency of other vitamins also. Signs of vitamin deficiencies. What is the cause? What do you think is the cause of vitamin deficiencies? The cause of vitamin deficiencies in hyperthyroid patients. Breakdown of fats, so vitamin isn't so soluble, improper digestion, absorption. What is the simplest? Think of.
Is it because it's using too much of it?
Yes. Simple explanation. Because the machinery is working so much, you need more raw materials, right? And because most of your metabolic reactions, they are using vitamins as cofactors. So vitamins, they are being utilized at increased rate. So there are mostly, I have seen hyperthyroid patients with like a lot of vitamin deficiencies. So common, okay? And then coming to the diseases associated with thyroid hormone, simple endemic goiter. Simple endemic goiter is endemic means when a disease is, um, you know, it is related to a particular geographical area, right? So all the areas where there is deficiency of iodine in the dietary deficiency, mostly, mountain ranges, there is deficiency of iodine in the diet. The most of the world has like started fortifying salt with iodine, but there are still some populations which believe in consuming raw like rock salt and all these things. So there is still cases of, but it's on the decrease. Okay. Graves disease. So let's look at the picture of simple endemic goiter. We are going to look at the case of simple endemic goiter tomorrow. Okay. This is the cause. Why do you think this patient has goitrous enlargement of thyroid? Because of iodine decrease. I'll give you another hint. This patient is hypothyroid. That means if you look at the lab, T3, T4 levels, they are low. What is the cause of goitrous enlargement? Can you think about, okay, let me see the chart. Yes, hypertrophy due to negative feedback. Excess production of what? You're right. Excess production of TSH. Yes, good. So this TSH, so your pituitary is thinking that maybe thyroid gland needs to be stimulated. So it's producing more TSH. It's sending more TSH out to stimulate, and it's what it is causing is overgrowth of thyroid tissue because there's not enough iodine available to make that T3, T4. So this negative feedback circle is kind of messed up, and there is enlargement. Right? And in Graves' disease, this is the usual cycle of negative feedback inhibition, but then we have this chemical being produced by your immune system, which is a stimulating immunoglobulin. It is stimulating thyroid gland to secrete more T3, T4. And these individuals, the lab work is going to be like high levels of T3, T4, low TSH, okay, and low TRH. Of course, with other symptoms. And then you will do antibody profile and you're going to find TSI in the blood, okay? Because just if you look at the lab work, you cannot say it's Graves' disease, okay? It can be primary like hyperthyroidism. So you will have to look for an antibody. And typically, this is a female who is hyperthyroid. Okay. Second thing is there is exophthalmos. Now, it's exophthalmos. Okay. Exophthalmos is not seen in all the hyperthyroid pathologies. It is seen only in Graves' disease. Okay. Why? Because typically in these patients, okay, this thyroid stimulating antibody, it also causes proliferation of the tissues in the retrobulbar space. Okay, it stimulates thyroid gland, it causes goiter, it makes thyroid gland function more. It also causes proliferation of the tissue in the retrobulbar space. And exophthalmos is seen only in hyperthyroid individuals with Graves' disease. So if you're looking at a hyperthyroid patient with exophthalmos, you can very well say it is Graves' disease. Okay. And then you're going to do antibody profile and you're going to find that TSI in the blood. All right, we are recording. And then causes of hypothyroidism. Now the gland slows down, okay? Autoimmune cause, Hashimoto's thyroiditis, okay? So initially in this kind of disease, there is this antibody that is produced. This is a different kind of autoimmune disorder, okay, of thyroid gland, where initially there is formation of antibody which stimulates thyroid gland, okay, and then it causes destruction of thyroid tissue later on. So initially, for a period of 3 to 6 months, there is hyperthyroidism followed by atrophic thyroiditis. Thyroid gland atrophies. It involutes, shrinks, stops functioning. Second type is iatrogenic, if the patient is on iodine 131 treatment, or due to some reason this thyroid gland was removed because of thyroid cancer, because of some reason. Okay, there's third kind of disorder with there are that can be congenital. Okay, and then there are drugs like iodine excess. I told you what's the name of this, Wolff's Chekhov effect, when excess of iodine in the salt can depress thyroid gland. Okay, some anti-thyroid drugs, like if the patient is accidentally taking, that doesn't usually happen, but yes, or if the patient is taking overdose of anti-thyroid drugs, okay, and there is this drug amiodarone, okay, which is used for atrial fibrillation, that also causes hypothyroidism. So that means it's very commonly used drug. Its trade name is cardarone. That means if your patient is on cardarone, you have to monitor T3, T4 levels at least every 3 months. Okay, doesn't mean that you cannot give amiodarone, because it's very effective drug in atrial fibrillation. Okay, but then there are certain drugs, they you have to monitor the patient for the side effects. Okay, and then there is diffuse non-toxic goiter, okay, due to iodine deficiency. We just saw endemic goiter, or there are environmental goitrogens, like, in some individuals, they say there is this cabbage, broccoli, or there are some kind of goitrogenic foods, which turnips, right, which can cause hypothyroidism. Now, my point is, foods, if you are consuming them in moderate amounts, they should not like depress thyroid gland. But if you are eating like cabbage morning, breakfast, lunch, dinner, then do not, you cannot say broccoli will cause hypothyroidism. It's good, right? But if you're, and they're not goitrogenic for all, for everyone. They have goitrogenic potential in certain individuals. Again, there is some genetic factors, environmental factors, some poorly understood epigenetic mechanisms. All right. Or it can be secondary due to hypopituitarism or hypothalamic disease. All right. Okay. All right. Yes, I will slow down. So can you read everything now? I will write in the way you guys can read, okay? All right. Let's move on. And these are the signs and symptoms of hypothyroidism. So if you will see a hypothyroid individual, okay, this person is weak, the patient will complain of weakness, tiredness, dry skin, cold intolerance, hair loss. Typically, if a person has like untreated hypothyroidism for maybe a couple of years, you will see that, lateral 1/3 of the eyebrows be lost. I'm talking about untreated. If like the patient is ignoring signs and symptoms and it just letting hypothyroidism get worse, then hair loss can be like really bad. Okay, there is poor memory, difficulty in concentration, constipation. very common presenting complaint. Weight gain in spite of poor appetite, dyspnea. There may or may not be hoarseness of the voice. Okay. Now you'll say hoarseness of the voice. Why there should be hoarseness of the voice? This is because of fluid accumulation, and sometimes there is like swelling of the vocal cords causing hoarseness of the voice. But I have a question. A person with goiter comes to you with hoarseness of the voice, with large thyroid gland. What can be the cause? Compression of something. Okay. Compression of what? Which nerve? Compression of, no, what you have like close to your, yes, good. Recurrent laryngeal nerve. It's very common. We have seen patients presenting with hoarseness of voice with this big, goiter, with pressure on recurrent laryngeal nerve. And sometimes if there is like locally invasive thyroid carcinoma, without goitrous enlargement, the patient may have hoarseness of voice because of deposits of cancerous tissue around recurrent laryngeal nerve. Okay. Menorrhagia, I told you, hypothyroid females, they tend to lose more blood during their menstrual cycles, or they may have polymenorrhea. Okay. Paresthesia. Paresthesia is altered sensation because of, again, neural weakness. Okay, weakness of the nerves, conduction weakness. Okay, if you'll examine this patient, you'll see a dry, coarse skin, cool extremities, puffy face, hands and feet. This is myxedema, non-pitting edema. Okay, there is non-pitting edema. What is the cause of non-pitting edema in hypothyroidism? Did I tell you the other day? Did I talk about hyaluronic acid? So what happens is in your subcutaneous space, let's talk about the space underneath your, skin of your dorsum of the hand, or anywhere in the body, you have fluid, right? You have interstitial fluid, interstitial fluid, right? This fluid exists in two forms. There is a free fluid, which is like freely absorbed or, exchanged with the circulatory compartment. There's another, like about 20% of the interstitial fluid exists in the gel form. That means hyaluronic acid and chondroitin sulfate and the fibers in your connective tissue, they kind of form this, gel in your subcutaneous space, and water exists in this space. Okay, so what happens here is, like, because the edema, so there is two kinds of edema. There is edema related to cardiac failure, renal failure, liver failure. When there is excess fluid in the body, then you will have increase in the level of free fluid in the tissue space, and the patient will have pitting edema. Pitting means if you will press against a bony prominence and then you remove your finger, there'll be a pit, and it will take like around 15 to 20 seconds for that pit to disappear. In non-pitting type of edema, if you will, there'll be edema, you can see puffiness, but if you'll try to press, there'll be no compression, there'll be no depression. That is because there is free fluid, but it is in this gel form. Okay, and because this patient is having like increased level of hyaluronic acid, there is accumulation of fluid in the gel form. Peripheral edema, non-pitting type. Okay, there is delayed tendon reflex relaxation. This is typical of hypothyroid patient. Okay. Carpal tunnel syndrome, again, because of typically, your body is forming this chemical more. There is accumulation of hyaluronic acid in the tissue space. It is a component of ground substance in the areolar tissue of your yeah. It's a part of your ground substance of the areolar connective tissue, loose connective tissue underneath your epidermis. Okay. All right. So these are all the signs and symptoms of hypothyroidism. Okay. And then in Hashimoto's thyroiditis, I told you it's again autoimmune. Okay. It's autoimmune, but antibody initially stimulates the thyroid to produce increased level of T3, T4, but then after about 3 to 6 months, there is decrease in T3, T4 levels, and then there is total thyroid failure ultimately. Okay, total thyroid failure. Okay. So this is a patient of, this is a hypothyroid patient. You can see puffiness of face, okay, periorbital edema. This patient is not showing hair loss, having plenty of hair, but the puffiness is due to hypothyroidism, okay? And then coming to cretinism. What is a cretin? What do you understand by cretinism? A child not developed appears in kids, babies. Yes, congenital. Hypothyroidism. If a baby is born with a hypofunctioning thyroid gland. Okay. What are the features of cretinism? Short stature, severe mental retardation. Okay. There is large tongue, hot belly, dry hair, dry skin and hair, right? Yeah. Poor appetite. These are the signs of cretinism. But again, cretinism is rare in USA because of screening at birth, which is like congenital hypothyroidism. Is that clear now? It's why thyroidism. Okay? Poor appetite. Yeah. All right, so these are all the features of cretinism. All right, let's move
Doctor,
on.
what are they looking for when they diagnose for cretinism?
You'll have a short stature baby, delayed milestones. Okay, the parents, they will come to you and they'll say, okay, the child is not growing up. Child is like maybe 8 months and is not like holding the head or is not like responding. So delayed milestone, okay. Because initially there'll be no signs of mental retardation, okay. But if the child is 2 years old and is short statured and mentally retarded, okay, then you can get T3, T4, TSH levels done to diagnose cretinism. Signs and symptoms, okay, yeah, I can go back. So short stature, all right.
No,
Did you get your, okay,
I,
Roberto,
I
yes?
got those, doctor.
Mhm.
I got it. I got it. I was looking for the TS I got it. Thank you. Thank you.
Yeah, thyroid hormone levels, right? Yeah, because any child who's not, who's having delayed milestone, not responding, large tongue and hoarse cry, poor response, not sleeping well, not eating well, you know, you have to get like all the profile done, right? And then you will find out the cause. So short stature, severe mental retardation, okay. And then there is pot belly, large tongue, poor appetite, and then there is poor appetite, hoarse cry, right?
Yes, thank you, doctor.
Okay. All right. Okay, Michael. Let's move on, and then we have few questions, and then I think we are going to uh, move to the next chapter. And this question says a patient has an elevated plasma T4 concentration, okay, a low plasma TSH concentration, and her thyroid gland is smaller than normal. What do you think is the cause? So we have increased T4, low TSH, small thyroid, smaller than normal. Okay, so these are the findings we have, just 3 findings. What do you think? So let's look at all the options one by one. Let's look at option A. It says D. Yes, it's D. Okay. Let's look at all the options. A lesion in the anterior pituitary that prevents TSH secretion. Okay. Yes, that justifies low TSH, but does not justify increased T4 levels, right? So patient is taking propyl thiouracil. Propyl thiouracil is anti. Wait a minute. It is anti-thyroid medication, right? So if patient is taking anti-thyroid, that doesn't explain increased T4 levels, right? Wrong choice. No, this is also C is the right choice. I'm sorry. C is the right choice. Patient is taking thyroid extract. Let's come back to this. And who answered D? Tal, you answered D. The patient is consuming large amount of iodine. If the patient is consuming large amount of iodine, that should depress thyroid, and patient cannot have increased level of T4. Okay. Graves disease, again, Graves disease. Can it be Graves disease? But Graves disease will not cause shrinkage of thyroid gland, right? Because of course there will be increased level of T4. You can explain that. Low TSH, yes, quite explainable because of that TSI, but that does not explain small thyroid gland. If you have TSI stimulating immunoglobulin, it will not let thyroid gland shrink. Only explanation here that fits according to me. If you think otherwise, please let me know. Do you still think this is the right choice? The patient is taking thyroid extract. Does that fit? Or not? All right. Yes, patient is hypothyroid and is on thyroid therapy, thyroid supplements, you can say. Okay, now patient is taking thyroid supplement, okay, and there is low TSH because of negative feedback, okay, and because of low TSH, there is small thyroid gland. Yes, that is Wolff-Chaikoff effect. Remember, we talked about it. Chaikoff effect. Wolff-Chaikoff effect, there is depression of thyroid gland. So in that case, T4 levels should be low. That if, you know, the question said low T4 and small thyroid gland, yes. But the T4 levels, they are high, and this increased T4 because, you know, when you're taking thyroid supplement, you take thyroxine. You do not have market preparations of T3 available. T3 is not, T3 preparations, they are not available because they are unstable. You have thyroxine, that is T4, okay? And this T4 is deiodinated at the level of tissues, we have read that. So when it is typically, you know, written, it's increased T4, that supports choice D. C, I'm sorry, choice C, okay? Does that make sense, everybody?
Yes.
All right. Next. Now this, I would say maybe that choice is not here. You can think out of the choices in this question. 30 years old woman reports to the clinic for a routine physical examination. Examination reveals she's pregnant. Her plasma level of TSH are high. So pregnant, high TSH. The total thyroid concentration is normal. So T3, T4, normal. Right? Which of the following best reflects patient's clinical state? Graves' disease, Hashimoto's, a pituitary tumor secreting TSH. How do you explain? So there is only one, you know, abnormality here. TSH levels are high. And something in the findings. Can you think of, like, if you do not look at the choices, can you think of something which might be causing increased TSH levels? E, the patient is taking thyroid extract. Okay. F, increased DBG levels. That is another choice I would like to add. Now think about the choices. TBG, thyroid binding globulin, remember, which keeps thyroid in the bound state. Remember, we looked at the stimulants and depressants of thyroid hormone secretion, right? And we said that increased TBG levels enhance TSH secretion. Why? Because pregnancy and any hyperestrogenic state, okay? Let me explain another fact to you. Whenever a female has increased level of estrogen due to any reason, that may be pregnancy, even obese female, they have, you know, they are hyperestrogenic, okay? So this high level of estrogen, they increase secretion of thyroid binding globulin by liver. So this thyroid binding globulin, this keeps thyroid in the bound state. So there is decreased level of free T3 and T4. And remember, I told you it's free T3, T4, which causes inhibition of TSH secretion. Okay, now because, sorry, increased level of, so There is deficiency of free T3, T4 in this patient because most of the thyroid normal level, she has normal T3, T4, but most of the T3, T4 is in the bound state. And there is reduced T3, T4 in the free form. Because there is actual relative deficiency of T3, T4, there is reduced negative feedback on the TSH secretion from anterior pituitary. Does that make sense, guys? So there is pregnancy, increased levels of thyroid binding globulin, okay, increased or deficiency of free T3, T4, loss of negative feedback inhibition, increased level of TSH. Make sense now? Make sense or not?
Makes sense.
All right. To everyone, I suppose, right? Okay.
Yes.
Next question. A patient has a goiter associated with high levels of both. Now this should be both level TSH and TRH. Both are high. Okay. Increased heart rate. What is the diagnosis? What is the diagnosis? Yes. Correct. Okay. Is everybody good? I'm going to move on to the next question. And a 46 years old man has puffy skin and is lethargic. What was it? Okay, I'll go back. It was B. Hypothalamic tumor secreting large amount of TRH. So high TRH is stimulating. Double check mark. Okay. This is the right answer. All right. Is that clear now, Michael? Okay. All right. Is this question clear with everyone? Increased TRH increases TSH levels, okay? So this causes increased level of T3, T4 because they did not say anything about T3, T4, but they are saying heart rate is elevated. So that means there is increased level of T3, T4. That is the cause of increased heart rate. So the whole hypothalamic pituitary thyroid axis is, is hyper functioning. All right. Next question. 46 years old man has puffy skin and is lethargic. His plasma TSH concentration is low. Okay. So puffy and lethargic means maybe this patient has low T3, T4 also looks like, hypothyroid. His plasma TSH concentration is low and increases markedly when he is given TRH. What is your diagnosis? Now think about the diagnosis, guys. Take a minute and explain, tell your choices, and after that we'll take a break because I think this is the last page here. Yes. Hypothyroidism due to abnormality in pituitary gland. Due to abnormality in hypothalamus. It's not hyperthyroidism. So let's cut both the hyperthyroidism. Okay. Abnormality in between D and E, right? It's not C because it's not primary abnormality of the thyroid because we have low TSH. But look at this. Patient's condition improves when he is given TRH. He is hypothyroid and then you give him TRH, okay? And there is improvement. So should it be D or E? Yes, it is D. Pituitary is fine. That is why pituitary is responding to TRH. If pituitary is not fine, it will not respond to TRH and condition will not improve. Make sense?
Also, can it also be because the hypothalamus isn't releasing that thyroid releasing hormone?
Yes, that is because that is what this choice says. Hypothyroidism due to an abnormality in hypothalamus. So this is hypothalamus failure. So you're giving TRH and the whole axis is responding. Make sense? All right. So let's go for a break and then start with parathyroid when we come back. Okay. All right.
Yes.
Okay, guys, I'll see you at 9:02. All right. Thank you, Leslie. All right. So is everybody back? Are you guys back? Am I audible, guys?
You're good.
Yeah, we can hear
Okay.
you.
Yeah. All right. Yeah. Okay. So we are going to learn about calcium homeostasis. Okay. So calcium ions. Can you enumerate the functions of calcium ions in the body? We are going to complete all these objectives. And what are all the functions of calcium ions? Muscle contraction, yes. Contraction. All right. What else? Clotting, blood clotting. Okay, it's one of the cofactor in the clotting pathways. Osteogenesis, yes. Osteogenesis. Okay, can you explain? You all know, right? If there is hypocalcemia, cell signaling, very good. Yes. Calcium is second messenger in some of the pathways for hormones. So, yes, signaling, cell signaling. And so I think you all know that in case of hypocalcemia, you might have heard of tetany, right? Hypocalcemic tetany. And Trousseau's sign, and there is Shostak sign. You might have done that with Dr. Burdett in your clinical labs, right? What is the cause of tetany in case of hypocalcemia? Why do you think tetany means spasmodic contractions of your muscles? Hypocalcemia, how do you think hypocalcemia causes? We know, right? Calcium is required for muscle contraction, and if there is hypocalcemia, there should be muscle relaxation. What is the cause of? So you've heard of tetany, right? You know hypocalcemia causes tetany. Yes. How do you think that happens? So we know about sodium channels, all of us, right? The sodium channels which are responsible for depolarization during muscle contraction, right? We know that there is influx of sodium ions and there is depolarization, and efflux of potassium ions and there is repolarization. Cells cannot conduct electrical impulses. Okay, yes, that is one way of saying it, but calcium ions, they are required for stabilization of sodium channels. That's the explanation. Calcium ions stabilize sodium channels. Okay, so in case of calcium deficiency, these sodium channels, they become unstable and there is uncontrolled, unregulated sodium influx resulting into muscle twitchings, muscle contractions, and sometimes spasmodic contraction of the muscles. Make sense? Okay. Inactivation of what? Sodium channels? Yes, they delay. You're right, yes, inactivation of sodium channels. So sodium channels inactivation gates, they remain open if there is hypocalcemia. Make sense? So calcium ions, which is still poorly understood, but this is well understood that calcium ions, they regulate activity of sodium channels. They stabilize them, and some of the schools, they say that they have a role to play in the closure of these sodium gates, right? You know, these are voltage gated channels and they have inactivation gates. Okay, so the right explanation for hypocalcemic tetany is that calcium ions, they play a very important role in stabilization of sodium channels. And in the deficiency of calcium ions, sodium channels, they become uncontrolled, they become unregulated, and there is like depolarizations and muscle contractions and twitchings, sometimes sustained muscle contraction over longer periods of time. Make sense? So these are all the functions of calcium ions. And there are two, and then there is third hormone. These three hormones, they are responsible for calcium homeostasis. Okay, parathyroid hormone, vitamin D, and calcitonin. And we are going to look at the roles of these hormones in calcium homeostasis. But first, we need to know how does calcium exist in our body. Okay, we have 9% of the calcium is this is the calcium ions in body fluids, plasma. Okay, not in the body. All right, within our plasma, okay, 9% it is complex to anions like phosphate. The principal anion for calcium ion is phosphate. So calcium phosphate salts, that is 9% of calcium, exists in the form of calcium salts. Okay, 41% is bound to the proteins, principally bound to albumin. Okay, 50% is ionized calcium. Okay, and this is the calcium we are concerned about. This is the active form of calcium ions in the plasma. All the functions we are talking about calcium ions, blood clotting, cell signaling, that is calcium ions. And this is the most active form of calcium ions. Okay, so 50%, that is 1.2 millimoles per liter. That is the concentration of calcium levels in the free form, in the ionized form. Okay, when we are estimating serum calcium, we are estimating only ionized calcium. We're not looking at protein bound calcium or calcium salts. All right. Okay, now, so this is the intake and output of calcium ions. In your bones, you have like 1 million milligram of calcium ions. Okay, and every day 500 milligram of calcium is deposited and 500 milligram is dissolved from the bone and is, dissolved in the plasma. Okay, cells, they have 13,000 milligram of calcium ions, and there is exchange of only like 1/10 of it with extracellular fluid. Okay, and then we intake roughly like on a standard diet, we take around 1,000 milligram of calcium ions per day, out of which 900 milligram is removed in the form of fishes, and 100 gram is like overall absorbed. So 350 milligram is absorbed and 250 milligram is, secreted. In total, there is a net absorption of 100 milligram of calcium from gastrointestinal tract. Okay, and there is 100 milligram of calcium ion, that is the same 100 milligram we have gained from GIT, we are losing from the kidneys. So that is the cycle intake. So for everything, not only for fluids, for calcium ion, everything we are consuming has to be like, so intake and output, there has to be a balance. Okay, in case of if there is calcium deficiency in the body, then kidneys, they will not remove 100 milligram per day, but the 100 milligram per day which we are absorbing from gastrointestinal tract, that is going to be a part of the pool in the extracellular fluid. So you can always, you can always shift the balance between gastrointestinal tract and excretory system, kidneys. Okay, so out of which, so around 1,000 milligram is filtered and 100 milligram is reabsorbed by the, 100 milligram is removed and 9,880 milligram is reabsorbed. Make sense? So there is this precise balance in the calcium ion concentration in the plasma. Okay, and so here, that means anytime there is changes in the plasma protein concentration or plasma anion concentration. So if you have excess of phosphate ions, there is going to be relative deficiency of free calcium ions. Okay, anytime there is more availability of plasma protein concentration, there is going to be deficiency of free calcium ions. Okay, so calcium ions in the blood, they are affected by plasma protein concentration and plasma anion concentration. And how does this acid base abnormality, how do acid base abnormalities relate with calcium ion concentration? Let us look at the next slide, because we said yes, so calcium levels, they, in case, this will be clear in the next slide. Okay, yeah, let's look at the next slide. So here, this is albumin. Okay, let's look at a single albumin molecule, and this albumin molecule, it is binding hydrogen ions, okay, and calcium ions. Okay, but say for example, this is albumin and it has 6 binding sites. Okay, or 8 binding sites. So 4 of the sites, they are occupied by hydrogen ions. Okay, and 4 sites, they are occupied by calcium ions. Because, all right, in case of acidemia, what will happen? Acidemia means you have excess hydrogen ions in the body. All right, that means those excess hydrogen ions, they will replace calcium ions from the albumin. Okay, and there'll be increase in the ionized calcium ions. Okay, so when you have hydrogen ions excess in the body fluids, that is the case with acidemia. Say a person has diabetic ketoacidosis, or a person has lactic acidosis. In that case, excessive hydrogen ions, they are going to replace calcium ions. They are going to occupy more binding sites on the albumin molecule, and you're going to have more free calcium ions in the blood. So calcium ion level in the blood, they are going to increase, because what we are measuring ionized calcium. On the other hand, you have a patient, this patient who's like really anxious and is hyperventilating, okay, and is huffing and puffing. She's doing like this. What is she removing from her body? When you hyperventilate, what are you doing? Carbon dioxide, right? So you're losing a lot of carbon dioxide. When you're losing carbon dioxide, what are you losing? Carbon dioxide is equal to water, okay? So let's go back to whiteboard. Just remember one thing for the rest of the physiology chapters. This is going to come again and again and again. Carbon dioxide in the body fluids, it combines with water to form carbonic acid. Okay, and then this carbonic acid is like really unstable and it breaks down into hydrogen ions and bicarbonate ions. Just remember, when you have excess of carbon dioxide, that is equal to excessive hydrogen ions, and there is acidosis. For example, a patient has got bullet injury on the chest and is not able to breathe in or out normally, is accumulating carbon dioxide in the blood. This carbon dioxide is going to become hydrogen ions. Just a simple correlation. Hypercapnia is going to cause acidosis. On the other hand, if this patient is blowing off too much carbon dioxide, anxious patient, this patient is blowing off or is removing too much hydrogen ions from the body, is having a fear of going into alkalemia or alkalosis. Alkalosis is better term. Alkalosis. Makes sense? Right? Alkalosis. Now, alkalosis means there is deficiency of hydrogen ions. So when there is deficiency of hydrogen ions, there are more binding sites available for calcium ions. So this albumin is going to bind 6 calcium ions instead of 4. And what are you going to get? The patient who was anxious will start feeling the sensation, the tinglings, paresthesias, maybe carpopedal syndrome because of hypocalcemia. Okay? So when a patient has alkalosis, this can cause hypocalcemia and the signs of hypocalcemia. Yes. Is that clear? Let's go back to our now it should be clear. So in case of alkalemia means low hydrogen ion concentration in the blood. Low hydrogen ion concentration means there is availability of more free sites on the albumin, okay, leading to relative deficiency of calcium ions, or there is hypocalcemia, and this patient is going to feel all the early signs of hypocalcemia. And can you treat this patient like in the OPD, right there, by simple procedure? She's like, I don't know, something is happening, something is going to happen. Oh, now I'm getting this tingling and something. She's losing too much carbon dioxide. You'll ask her to breathe in a paper bag. Okay, and she's going to take that carbon dioxide back and is going to correct alkalosis and hypocalcemia. Is that clear? Make sense? Yeah. So breathing through a paper bag can correct anxiety related hypocalcemia. All right. Now let's look at parathyroid glands. So you have like 4 or 5 parathyroid glands, mostly 4, embedded in the posterior surface of thyroids, lateral lobes. Okay, so if you tilt thyroid gland, and you can see there are 4 tiny glands, pea-sized glands, embedded in the tissue, in the thyroid tissue. Okay, and if you cut them and look at the section, look at the histology slide of these glands, you will see tiny rounded bodies within thyroid tissue formed by compact irregular rows of cells. So there are compact irregular rows of cells. There is no like a clear-cut structure, okay? And what do these cells secrete? You have chief cells in the parathyroid gland, okay? So these are chief cells, and then you have oxyphil cells, which do not have any typical function, and these are the capillaries with red blood cells in them, okay? And chief cells, they secrete parathyroid hormone. This parathyroid hormone acts on three principal tissues. Parathyroid hormone is going to act on bones, kidneys, and intestine. These are the three tissues you will find parathyroid hormone receptors. And what kind of receptors? Where will the receptors be located on the cell? What kind of receptors you think parathyroid hormone has? Is it one of PDK8 hormones? No. So it has cell membrane receptors. All right. Cell membrane, yes, good. So the stimulus to secrete parathyroid hormone from the chief cell is low calcium levels. Okay, whenever you have like more free calcium ions in the blood, as we saw in case of acidosis, okay, excess calcium ion is going to depress parathyroid gland, okay. So low calcium ion levels, they will stimulate our chief cells of the parathyroid gland to secrete parathyroid hormone. Parathyroid hormone will act on bones to cause increased resorption, or they will increase osteoclastic activity in the bone to leach out calcium ions from the bone. Second effect is on kidneys, okay? The kidneys, this is very important effect. Reduced absorption of phosphate ions, reduced reabsorption of phosphate ions. So parathyroid hormone actually favors phosphaturia, okay, causes removal of phosphate ions, okay, increased calcium ion reabsorption, okay, and increased urinary CAMP, all right. And then on intestines, it causes increased calcium absorption through vitamin D, all right. Overall effect is increased plasma calcium ions left, okay. So here, if you look at the chief cell secreting parathyroid hormone acts on the bones, causes calcium reabsorption, okay, acts on the kidney tubules, causes calcium reabsorption, acts on the kidney tubules, inhibits phosphate ions reabsorption, and also parathyroid hormone causes conversion of 25 hydroxy vitamin D to 125 dihydroxy vitamin D. Okay, so this is the effect of parathyroid hormone. Conversion of vitamin D to its final active form in the kidneys. Okay, then if you look at more effects, so vitamin D, then it's just like, growth hormone causes release of insulin-like growth factor from the liver, and then insulin-like growth factor act along with growth hormone to multiply or amplify its effect. Just like that, vitamin D is also going to act with parathyroid hormone to enhance calcium levels. It is going to cause bone resorption of calcium ion. It is going to increase reabsorption of calcium ions from the kidneys. It is going to inhibit its own conversion, okay? But if you look at the vitamin D effect, it increases phosphate reabsorption also, okay? And there's another effect, that is intestinal absorption of calcium ions. Now, calcium ion reabsorption, okay, is not from the intestine, is not a function of parathyroid hormone, has no effect on intestinal absorption of calcium ion. It does affect absorption of calcium ion from the kidney tubules, but indirectly, through vitamin D, it causes calcium reabsorption. Okay, now tell me, we have seen here that parathyroid hormone causes phosphaturia, right? What do you think is the benefit, or what is the effect of phosphaturia? Does it help parathyroid hormone to increase calcium ion levels in the blood? Because if you want to put in, you know, one simple sentence, parathyroid hormone increases level of free calcium ions in the blood. Its only job is it has to bring calcium ions from everywhere, from the bones, from the kidneys, from the intestines via vitamin D, right? So what is it doing? It is doing fourth effect, that is phosphaturia. That means because phosphate ions, they are principal anions for calcium ion. So by decreasing phosphate levels in the blood, it is increasing levels of free calcium ions in the blood indirectly. Does that make sense? So enhancing calcium ion levels, decreasing phosphate ion levels. So that means it wants calcium ion level. I mean, so think about it, you know, phosphate is the ion which binds calcium ions. So by decreasing phosphate ion level in the blood, it is increasing concentration of free calcium ions in the blood. Yeah, they do not have any other. Yes, phosphate is the principal anion in the bone also. So if you have, like, for example, you know, if let's imagine parathyroid hormone was increasing both calcium ions and phosphate ions in the blood. These calcium and phosphate ions, they are going to be deposited in the bone. They're going to, you know, hold hands, and they're going to get, you know, sit in the bones. Parathyroid hormone doesn't want that. Its primary job, it is given a function that you have to take care of calcium ions, not the bones. Think about it. Vitamin D is different in this aspect. Vitamin D, it is increasing calcium reabsorption. Also, it is increasing phosphate reabsorption. That is why vitamin D is important for bone health. But if a person has increased level of parathyroid hormone, bone health is going to suffer, because parathyroid hormone is going to leach out calcium ions, and it is going to remove phosphate ions. So you need both calcium and phosphate for bone health. Make sense now? It is going to be clear, okay? Because we are going to talk more and more about calcium ions, and then next week we are going to talk about bone physiology. So we are going to repeat these things, okay? All right. And when you look at the actions, if you look at the bone cells, it has its receptors on osteoblasts, osteocytes, and osteoclasts also. So it increases osteocytic osteolysis and also increases osteoclastic activity. Okay. So overall, there is enhanced osteoclastic activity. Activity. All right. The kidneys, it increases calcium reabsorption, but it decreases phosphate reabsorption. This effect you can ignore right now. Doesn't have much role to play in sodium reabsorption. So let's not concentrate on this. Okay. But this is very important. Increases the levels of 125 dihydroxy D3. Intestines, it causes calcium absorption and phosphate absorption through vitamin D. Indirect. Okay, make sense?
Yes.
All right. So here, look at the effect of parathyroid hormone in the proximal tubule. So we are looking at a nephron. Okay. Parathyroid hormone acts at two different locations on the nephron. It acts on PCT, that is proximal convoluted tubule. it also acts on DCT. Let's first look at its effect on PCT, that is proximal convoluted tubule. What does it do? It acts on PCT, okay, and it decreases reabsorption of phosphate ions. Okay, if there was no PTH, okay, then there'll be like maybe 80 to 90% of reabsorption of phosphate ions. Under the influence of parathyroid hormone, only 70% of phosphate ions they are reabsorbed, okay, and it does not let like most of it lets like at least 15% of phosphate ions go. 15% they are reabsorbed in the later part, but I mean in the descending limb of loop of Henle, that is not PTH dependent. Non-PTH dependent. But reabsorption of phosphate ions in the proximal convoluted tubule, it is decreased. Okay, so how does decreased phosphate reabsorption affect ionized calcium ion levels in the blood? I think you have your answer. Can you answer this question? Yes. So the idea is that if you remove the friend of calcium ion, phosphate is the friend, you'll have more calcium ions, free calcium ions. Okay. All right. So this is parathyroid hormone and this is parathyroid hormone receptor coupled to a G protein. Okay. And through this G protein coupling, it increases adenylyl cyclase activity and causes conversion of ATP to cyclic AMP. Cyclic AMP then causes phosphorylation of certain proteins. There is like this cascade which increases activity of sodium phosphate co-transporter. Okay, so there is increased activity of sodium phosphate co-transporter, and this is how phosphate ions they are absorbed from the lumen of proximal convoluted tubule and they are transferred to the blood on the basal side. Make sense? Of course, you know, you'll find out like through this course that in the kidney tubular cells you have sodium potassium pump everywhere. Okay. And this, you know, sodium potassium pump causes deficiency of sodium ions. Okay. And because of deficiency of sodium ions inside the cell, there is secondary active transport of phosphate ions along with sodium ions through sodium phosphate co-transporter. Okay. This is not important that what kind of transporters we have. This is more important that on proximal convoluted tubule, on the cells of the proximal convoluted tubule, when parathyroid hormone binds, it, you know, inhibits, I'm so sorry. It inhibits, so this, it inhibits this pump, sodium phosphate pump. So there is decreased reabsorption of phosphate ions from the tubular cells. So that is if you do not have parathyroid hormone, if parathyroid hormone was not binding with the receptors, you will have this reabsorption. Okay, so because of cyclic AMP production under the influence of parathyroid hormone, this pump will not work and phosphate will not be reabsorbed and this phosphate will be removed along with the filtrate. Okay, of course 15% more will be reabsorbed in the descending limb of loop of Henle, but 15% will be excreted. Make sense? This is how parathyroid hormone is going to work. It is going to inhibit absorption of sodium phosphate by sodium phosphate co-transporter. Is that clear? Yeah, I'm sorry about that. All right. And then if you look at the action of PTH on distal convoluted tubule, this is distal convoluted tubule. Okay, distal convoluted tubule, So this is about calcium ions. Normally what happens is 67% of calcium ions, they are reabsorbed in the proximal convoluted tubule unregulated. That means it is not under the influence of vitamin D or parathyroid hormone. It has to happen without any hormone. Okay, so 67% of calcium is going to be reabsorbed anyways, parathyroid hormone or no parathyroid hormone. Okay, then we are left with 33% calcium ions in the filtrate. Now this filtrate flows through this descending limb and then through ascending limb, and 25% is again reabsorbed, and this is also unregulated, not under the influence of any hormone. And when the filtrate reaches distal convoluted tubule, then parathyroid hormone, it binds with its receptor and increases reabsorption of calcium ions. 8% of the calcium ion is reabsorbed under the influence of parathyroid hormone. And if there was no PTH, right, then instead of losing 1% calcium, we are going to lose 9%. Okay, so this kind of, you will see when we'll be talking about renal system, you'll learn about regulated and unregulated absorption. So this is unregulated. Most of the substances, they are reabsorbed in this proximal convoluted tubule. They're not most of. Okay. That means this parathyroid hormone, what is it doing? It's fine-tuning calcium reabsorption. Okay. It has its effect only on 8% reabsorption of calcium, and that's a lot. Okay. And if there is no parathyroid hormone, we'll be losing that, extra 100%. We were like, 100 milligram we were absorbing. All right. So that is, so now you can look at the effect of parathyroid hormone on proximal and distal convoluted tubule. On proximal convoluted tubule, what does it do? Decreases phosphate reabsorption. Distal convoluted tubule increases calcium reabsorption. Is that clear, everybody? Okay. Thank you. All right. Okay, it will be clear, don't worry. So here you can see overall effect of parathyroid hormone on plasma calcium level, or how plasma calcium levels and parathyroid hormone secretion is affected. As plasma calcium levels, they start to fall like beyond 10 milligram per deciliter. There is, steep increase in secretion of parathyroid hormone. Okay. And beyond like 8 milligram per deciliter, there is 100% increase in the parathyroid hormone secretion. So as plasma calcium levels, they decrease, there is increase in the PTH secretion from parathyroid gland. Okay. Or you can also talk like this. As the parathyroid hormone, levels, they decrease, plasma calcium levels, they also. So this is the normal range, 10. So we say this is the normal range, 10 to 12 milligram per deciliter. Okay. As there is hypocalcemia, parathyroid hormones level, they increase. As the calcium levels increase, PTH levels, they develop. Okay. So that is the effect of parathyroid hormone on calcium levels. Okay. And then next thing we are looking at is hydroxylation of vitamin D. Okay. So vitamin D, we have vitamin D in its precursor form, which is not like physiologically active, and that is 7-dehydrocholesterol. Okay. We have this form in our skin. It is present in our skin cells. Okay. And when ultraviolet light rays, they fall on the skin, 7-dehydrocholesterol, it is converted to cholecalciferol. This is the form of vitamin D we consume in our diet also. So that means whatever we have in skin or whatever we consume, it is still inactive. It is not physiologically active. it needs to be activated in liver. There is 25 hydroxylation that takes place in liver. You have to remember 25 hydroxylation takes place in liver. Okay, now this is still inactive. 25 hydroxycholecalciferol still inert. Has no action. But as it reaches the kidneys, it undergoes 1-alpha hydroxylation. Okay, and it gets converted into 125 dihydroxycholecalciferol. This is the active form of vitamin D. Okay, some of 25 hydroxycholecalciferol is also converted into 24-25 dihydroxycholecalciferol, which is inactive, inert, has no physiological function. Excuse me. So you can tag this slide because you have questions and you have to be very clear that 25 hydroxylation, where does that happen? Liver, okay? And then 1-alpha hydroxylation, where does that happen? In the kidneys. And if a patient has kidney failure, right, there is like decreased activation of vitamin D, and there is deficiency of vitamin D, leading to, poor bone health. Inactive, like it's just removed from the body. It has no physiological function. It's inert. Make sense? All right. So tag this slide. I think you have a couple of questions in this slide, from this slide. Maybe 7-dehydrocholesterol or cholecalciferol. What is the dietary form of vitamin D? What is the form of vitamin D you have in your skin? Every part is important, okay? And wherever you have low calcium ions, right? Or parathyroid hormone increase and decrease in phosphate level concentration. These are all the stimuli for 1-alpha hydroxylation. Okay? All right. What are the actions of vitamin D? Now, vitamin D, vitamin D is considered as a hormone. Okay? And if I'd say it's a hormone, what kind of hormone is this? Is it steroid, protein? What kind of actions will it have? What will be the mechanism of action? And which of the 3 categories it falls? Because it's cholesterol. It is derived from cholesterol. Does that ring a bell? Steroid, right? So it behaves like a steroid hormone because it is derived from cholesterol. Okay, so all its actions on the target cell, they are like any other steroid hormone. What are the actions? In the intestines, it enhances calcium absorption and phosphate absorption. Okay, in the bones, it causes increased mineralization. Okay, so it is very good. How this is very important. It increases bone resorption of old bone. That is direct effect. So enhances osteoclastic activity. But then it makes, more calcium ions and phosphate ions available to mineralize new bone. Right? You have read about bone, that there is constant, recycling of the bone. That is what we are going to learn also next week in the physiology of bone. So always in your bone, new bone is being formed and old bone is being resorbed, and vitamin D plays a very important role. It increases resorption of the old bone and it makes more calcium ions and phosphate ions available to mineralize the new bone. Okay, so that is why, vitamin D deficiency has like it affects bone health. On kidneys, it increases calcium reabsorption. It is the, if you look at vitamin D, it has more effect on intestines and very weak effect on kidneys. Okay. Increases phosphate reabsorption, again a weak effect, so it brings phosphatines principally from intestines. Okay, so that is your vitamin D, and let's move on. Now let's look at the actions of vitamin D, the mechanism of action. Okay, so this is your vitamin D. Okay, 125-dihydroxy dihydroxy, it should be dihydroxy vitamin D. It binds with its receptor, and receptor hormone complex moves to the nucleus, and inside the nucleus it causes formation of new mRNAs, and there is appearance of new proteins. These new proteins, they are calcium transporters, which are incorporated on the luminal side of the intestines. Here we are looking at intestinal cell. This is intestinal lumen. Okay, there is increase in the number of calcium transporters on the luminal side. There is increase in the number of cal-binding proteins which bind with the calcium and cause their transportation within the cell. Okay, and also there is increase in the formation of sodium calcium co-transporters and hydrogen calcium co-transporters. Okay, so all these new proteins which are going to influence calcium reabsorption from the intestinal cell, their synthesis is increased under the influence of 125-dihydroxy vitamin D. Okay, so this is what vitamin D is doing. It's binding with its receptor. It is influencing DNA. It is causing gene transcription of multiple genes to form multiple new proteins. And all these proteins, what are they doing? They're working towards increased reabsorption of calcium ions from the luminal side. So there is this calcium transportation from the luminal side. This calcium binds with calbindin. This calbindin then, transports calcium ions towards the basal side of the cell, and in the basal side of the cell, these calcium ions, they are transported using two kinds of pumps. There is sodium calcium pump and calcium hydrogen pump. Okay, and also there is some paracellular absorption of calcium ions which does not depend upon vitamin D. Make sense, right? So this is how calcium ions, they're transported from luminal side to interstitial fluid and then to the blood vessels. All right. And then in the next slide, we are going to look at the phosphate reabsorption. Okay. So in the same way, new proteins, they appear, okay, in the cell, all right, and these new proteins, they are sodium potassium pumps, okay, and phosphatines pump, hydrogen phosphate and dihydrogen phosphate pumps, okay, because there is deficiency of sodium ions inside the cell due to sodium. Let's begin from here. Now, under the influence of vitamin D, new sodium potassium pumps, they are incorporated in the basal membrane. Okay, what is happening as a result? There is low sodium ion concentration inside the cell, which is the driver for sodium phosphate co-transporter. Okay, and this causes reabsorption of phosphatines. Okay, in the form of hydrogen phosphate and dihydrogen phosphate. Okay, and then there is incorporation of the transporters for phosphatines on the basal side also. So two new kinds of proteins are introduced into the phosphatine, which then drive secondary transportation of phosphatines through the luminal side of the cell. Okay, this is the effect of vitamin D on phosphate reabsorption from the intestines. Make sense? How are you going to memorize these two things? You are going to draw them with your own hands, okay? That is how you will never forget. All right? And then there is this third hormone, that is calcitonin. What is the source of calcitonin? parafollicular C cells of what? Where are they located? Thyroid. Good, right? So parafollicular C cells in the thyroid gland, they secrete calcitonin, and calcitonin, just remember, calcitonin release is triggered whenever you have excess calcium ions. It is opposite. Deficiency of calcium ions will cause PTH and vitamin D. Excess calcium ion will cause increased level of calcitonin, which is rare, right? It's very rare to have hypercalcemia, okay? What are the actions of calcitonin? Calcitonin has its receptors on osteoclasts and it decreases osteoclastic activity, okay? That means it decreases bone resorption, right? Although you have a question on this, it has minor role in acute regulation of plasma calcium ions. If you talk about like principal hormones responsible for calcium homeostasis, those are these two. Calcitonin in humans, it doesn't have much role to play in acute or chronic regulation of calcium ions. Only if there is deficiency of calcitonin or if there is excess of calcitonin secretion in the blood due to C cell tumors, you will see their effects. Make sense? Right? So, physiological, are we affected if we do not have any calcitonin in the blood? We're not affected. But of course, if we have excessive calcitonin being formed in the body, then of course it is going to cause decreased osteoclastic activity. It is going to have its effect in the body, which is rare again, okay? And then it's 9:52. I think we will carry on from here. All right. On Thursday. All right. Any questions?